The most common method of reconstruction performed today uses implants. That's usually performed as a staged approach, meaning that more than one surgery is usually needed to get the final result. The first stage involves placement of a temporary implant called a tissue expander. That's more or less a spacer that we use to create the general shape of the breast and the rough approximate size that we want to achieve. The expander is placed at the same time as the mastectomy. That's called immediate reconstruction. Or it can also be placed at some point after the mastectomy, anytime later in fact. That's called delayed reconstruction. The expander is placed either on top of the muscle or under the main chest muscle, the pec muscle. Most surgeons will place the expander under the muscle. And over time, the expander is inflated using salt water or saline to achieve the desired result. After completion of the whole expansion process, that's usually about 3 months, the patient goes back for a second procedure, again under a general anesthetic, and the expander is removed and the final implant is placed. And that's either a saline or a silicone implant based on the patient's preferences. Other procedures can also be performed at that second stage in conjunction with the tissue expander. The most common procedure is fat grafting or fat injections. And that's used to correct contour defects left behind from the mastectomy. The fat is injected under the skin and it improves the padding, the soft tissue padding over the final implant. So it decreases the chances of being able to see the waves in the implant shell, which is known as rippling. Some women are candidates for a single stage implant breast reconstruction. That's known as direct to implant or single stage or one step. The single stage and one step names are a little bit misleading. A lot of patients, unfortunately, will need more than one surgery still, even if they're having a direct-to-implant procedure. Again, the most common procedure performed secondarily with direct-to-implant is fat grafting, again, to achieve the best soft tissue coverage over the implant and the best cosmetic results. Most implant reconstructions are also performed in conjunction with Alloderm or another form of acellular dermal matrix. That's usually a cadaveric product. It's essentially a biologic sheet that we use in conjunction with tissue expanders or direct-to-implant breast reconstruction. Unfortunately, there are many misconceptions about implant breast reconstruction. The biggest is that it's an opportunity to turn a horrible situation into the breast augmentation that the lady always wanted. That's a problem because it really leads to heightened expectations, and the results of implant breast reconstruction are very rarely as nice as cosmetic breast augmentation. The main difference between a lady having implant breast reconstruction and a cosmetic breast augmentation with implants is the amount of tissue that she has to cover the final implant. The main disadvantages of breast implants is that the reconstructed breast typically feels cold. There can be significant rippling that the patient can see through the skin. That's waves in the implant shell that look like ripples. Over time, the body creates scarring. A scar shell or capsule develops around the implant that causes hardening. And there's a much higher risk of needing further surgery because of implant-related problems. So even though we say that the implant is permanent, unfortunately, there's a high chance, a high likelihood that it won't be the final procedure that the patient has. The other big issue with implant reconstruction is what happens when a breast cancer patient needs radiation. Radiation and implants don't mix well. Plenty of plastic surgeons offer implants in radiated patients. It's a very acceptable approach, but the evidence is clear. The literature is full of studies that has shown repeatedly that implants don't do well with radiation, and the failure rate is very high. By failure, I mean the implants aren't working out and the patient needs something else done. Typically, failure means the implants have to be removed and something else has to be done. The failure rate with implants in a radiated patient is close to 1 in every 3 reconstructed breasts. That's a very high failure rate. So when it comes to radiation, really, there is no substitute for healthy tissue being used as the main source of reconstruction. The success rates are much higher, and the risk of needing further procedures is very, very low indeed.